again. Welcome to the webinar on certifying encoding COVID-19 as cause of death. The next one, please. As you can see on this agenda, this 1 hour webinar is divided in 3 topics, followed by a questions and answer session. Please use the chat for your questions. The opening remarks would be by Dr. Sebastian, but Dr. Sebastian is right now in an important meeting. So I will start with my session, and then when he joins us, we can have the opening remarks. We hope this webinar help you on your daily work related to ICD, to COVID-19 and any other disease. The next one, please. The this one. The emergence of a new disease leads to uncertainty over how to register the new disease. So, WHO released the international guidelines for certifying and coding COVID-19 as cause of death. I'm going to go through just the main aspects of these guidelines. The next one, please. During this time, high quality information is more needed than ever. And the importance of the work of each one in this webinar is just crucial, is essential, because that certificate data is essential to develop policy response during and after pandemic. It's also important to identify who is dying, where they dying, and what are the associated medical conditions. It is used also to guide disease surveillance at local level, plan medical health research and quarantine measures, which have economic and social implications. We have a high demand for health information as in this time. The next one. Here we can see some issues found in many countries about underreporting of cases. First of all, it's a new disease, and all of us are still in the learning curve. A lot of research is going on. Some clinical manifestations were not reported in China, but were reported in other countries. I'm not going through all of them, but some of them are common to other causes of death, such as the lack of knowledge of the concept of basic cause of death. We are going to try to address some of these issues in this webinar. The next one. To standardize the register, the first important thing is to count the same things, so we need to have a definition and a code. The definition, the WHO definition for COVID-19 death is a death due to COVID-19 is a death resulting in a clinically compatible, probable, or confirmed case, COVID-19 case, unless there is a clear alternative cause of death that cannot be related to COVID disease, for example, trauma, there should be no complete period of recovery between COVID-19 illness and death. We add an important note here, a practical note. In general, it's best to avoid acronyms in death certificates, acronyms and abbreviations. But in this case, it's recommended to use COVID-19. What we see is variations of the terminology in many countries, and Germaine Martin will mention something about this. The next one. Here we can see the emergency codes in ICD-11 for COVID-19 disease. In summary, U07.1 is used for virus identified. It's confirmed case. U07.2 is used for virus not identified. So this is used when we don't have lab tests because the lab test is not ready or was not performing. This is used for clinical or epidemiological diagnosis of COVID-19. Here you have the website for these international guidelines, and both U07.1 and U07.2 are used for mortality coding as cause of death and also for morbidity coding purposes. The next one. This slide is for show you the ICD-11 codes for COVID-19, for the confirmed codes and for suspected or probable COVID-19. We don't know right now how long this disease will last, so we have also ICD-11 codes. And also globally there are countries that already adopted the ICD-11. The next one. Here it's a reminder of the ICD definition for underlying cause of death. The definition is the disease or injury which initiated the train of morbid events leading directly to death, or the circumstance of the accident or violence which produced the fatal injury. And Angela Hines will talk more about this underlying cause of death in her session. The next one. We brought two slides about the epidemiological situation of COVID-19 in the region of the Americas. In the Americas, the first case was reported in the United States in January 20. Since then, 54 countries and territories has been reporting cases for us. In 17 June 2020, and we know that cases changes every day, but yesterday we have almost 4 million confirmed or probable cases in the PAHO regional database. The total deaths is around 200,000, and we have 20 countries with community transmission. We have 12 countries that reported sporadic cases, and we have 17 countries with cluster of cases. Most countries in the Caribbean have sporadic and cluster cases. We can see in the next slide. Here we can see the distribution of cases and deaths by country in the Caribbean as of 17 June 2020. We can see that the countries that is not listed here, such Aruba, is not here because no cases was reported. We can see here that the French Guiana, Haiti, and Jamaica are responsible for the majority of cases and deaths. Thank you, everyone. The next one is we brought this slide to leave with you the PAHO website. On the way you have it's a very useful search of research. You have technical documents. We have this data that I presented very quickly are there, and the information is for the public and also for the health professionals. The next one. Many thanks, everyone. Stay safe, and I will invite Dr. Sebastian Garcia Saiso, the director of the Department of Evidence and Intelligence for Action in Health at PAHO, to give you some opening remarks. Thank you, everyone.
Thank you, Vilma, and good morning to everyone. Apologies for not giving my opening remarks at the beginning of our meeting today, but I didn't want to pass the opportunity to simply remark the importance of coding within the current pandemic, and how this basically relates to being able to have sound information for doing analysis that will enable us to later then set plans forward, and of course being able to do analysis on what is going on, and of course also predict or model what is going to happen to a certain extent into the future. I sincerely thank you all for taking this time and participating in this seminar. This is built around a need that we share in the entire region, and it's for all of you. So we appreciate your enthusiasm on this, and we appreciate also the effort that all of you are carrying out in your own countries. And of course, we're here to support you and to support your institutions in any way that we can from PAHO. I thank very much Vilma for putting this together, of course, with the help of all the team at EIH. And I thank also our brilliant panelists for their time today and for sharing all their knowledge and experience with all of us this morning. So without further ado, I return the microphone to Vilma, and I welcome you all to this seminar. Thank you.
Thank you, Dr. Sebastian. And I want to invite Angela Hines from CARFA to talk about the correct completion of medical death certificate. Over to you.
Thank you, Vilma, and good morning to everyone. I'm Angela Hines, and Senior Technical Officer in the Health Information, Communicable Disease, and Emergency Response Unit, the Caribbean Public Health Agency, CARFA. And I'm going to be continuing on what Vilma just said, and zeroing in and highlighting some of the key things to remember when correctly completing the medical death certificate, and do a little bit on the selection of the underlying cause of death, more specifically as it relates to COVID-19. Now, I have a short space of time, so I'm not going to go into all the aspects of completing the medical death certificate, but I'm going to highlight some key things, recognizing also among citizens listening that we have a mixed group, some who are very familiar with the system of completing, of certifying deaths, as well as many who are not. So I would like you to bear with me if I go over or re-emphasize certain things that have passed. Next slide, please. So I'm going to go through some of the guidelines for completion of medical certificate, look at the coding of the COVID-19 deaths, and also give a brief, some reminders when actually completing the medical certificate. Next slide, please. Next slide. Thank you. Next slide. So the physician's role in death certification is really very key. It is actually the source of the information that we use going forward from there. And therefore, it's really key that you provide a medical opinion of cause of death, and that is an etiological description of the order, type, and association of the events resulting in death. So that is a key part of the certificate that we zero in on to get information surrounding the death of the patient. Next slide, please. So the responsibility of the physician at this stage is to indicate the course of events, decide which condition is directly or which conditions are directly responsible for the death, and determine what antecedent conditions, if any, gave rise to the immediate cause of death we see. So next slide. So here we have, and we're going to focus today on the cause of death sections. And it's split up into part 1 and part 2. And in part 1, we see there are lines A, B, C, and D. And these are those conditions that directly relate to the cause of death of the patient. And part 2 will be the contributing conditions that contributed to the cause of death, but not necessarily directly related to it. Next slide. So looking a little closely at part 1, an entry must be placed on line A, and there in line A is usually the immediate cause of death, that final cause of death. B, C, and D are the due to, or as they say, consequence, and those are the conditions where you can ask the question, what caused this condition? And the underlying cause is that cause which Velma gave a definition just previously in her presentation, which says that this is a cause that initiated everything that went above. So what immediate cause happened in A was due to the condition that happened in B, which was due to what happened in C, or which was due to what happened in D. So in other words, what happened in D was the beginning that set off the train of events that resulted in the person's death in line A. Next slide, please. Continuing part 1, this is just an example to show that of the lines being entered. So here we see acute respiratory distress syndrome was due to pneumonia, which was due to a positively identified case of COVID-19. And this the last line here is actually the underlying cause of death, which is saying that COVID-19 gave rise to pneumonia, which gave rise to the acute respiratory distress syndrome, which killed the patient. So generally, we stay away from using mode of dying as it's uninformative. So this is just a general note in the sense that we try not to use things like old age, senility, because they don't give any information about the condition in particular. Report as accurately and precisely as possible, especially in the case of COVID-19. You need to identify if it was confirmed or if it was probable, suspect, or clinically or epidemiologically confirmed, because it's treated or it's coded differently so that anybody looking back can understand and be informed when they are looking at the overall conditions on the certificate. And that you note that the underlying cause of death can terminate at the immediate cause of death. So you can just have one line on the first line. Next slide, please. Time interval. This is something that we find generally in the region that is not completed, or if it is completed, it's in gaps. It's not complete. But again, we want to emphasize the importance of putting in the time interval between onset of the particular condition and the death. So it provides a useful check on the sequencing of cases. And so when we see the conditions and the times don't match, then it raises alarm bells that possibly the certificate may not have been completed properly, which happens. We all err in terms of when we're quickly completing a certificate. Also, it provides information on the duration of the illness. It gives us a lot of insight as into whether something has been quick, 2 days, or whether it's been prolonged for weeks or months or years, or that may be. It allows for the correct assignment of the code because depending on the duration would actually affect the code. So for example, something acute may be a few days, but however, if we see a few years, then we know it's more of a chronic condition. And there's a code, depending on the condition, the code is different, as well as the interpretation of the information is different. And complete where known, even if it's approximately, because sometimes depending on the situation, when you're completing the certificate, you may not actually know the exact time period, but even approximation would be helpful. Next slide, please. So here again, it's just an example showing you where the time interval has been placed. So you're seeing 2 days, 10 days, 14 days. So basically, 14 days prior to the death of the patient, the person was tested positive. 4 days later, they developed pneumonia, and 8 days later, they developed acute respiratory distress syndrome, and 2 days after that, they actually died. Next slide, please. Part 2. Now, this part is where you will put in all the other important disease and conditions that have contributed to the death, but have not necessarily led to the underlying cause of the death that was registered in part 1. Enter in order of significance. So even if you're going to put a number of conditions in part 2, still put them in order or in the logical sequence if it applies. The condition doesn't have to fit the sequence. If the condition does not fit the sequence of conditions that occurred in part 1, consider that condition for part 2. Only if they've influenced the course of the morbid events and have contributed to the fatal outcome. So something that happened 20 years ago that is completely irrelevant to the death, you would not put in part 2 just because it did happen somewhere in the life course of the person. Next slide, please. Examples of a COVID-19 with the comorbidity. So here we see acute respiratory distress syndrome was the immediate cause, and that was due to pneumonia, and it was due to suspected COVID-19. And if you notice in part 2, where I have circled in red, you're seeing coronary artery disease, type 2 diabetes, and the chronic obstructive pulmonary disease. Again, put in the second part. Next slide, please. So other concerns is that specifically rates the COVID-19. Persons with COVID-19, they may die actually of other diseases or accidents. So we have to be careful that when we're putting the information in the certificate, that we are mindful of the interpretation for the persons who are looking at it and going to code it and therefore use it for further understanding of the case. So you have to be careful if you really, as a physician, don't think that COVID-19 was directly the underlying cause of the particular death, despite the fact they may have had it, then it doesn't have to be put as the underlying cause of death. In the case, sorry, can you go back a slide? In the case where you think that COVID-19 aggravated the consequences of the accident or the particular death, you may report that in part 2. And then, of course, please remember to indicate any manner of death in part 1 that exacted any kind of, for example, if there was any incident or any external cause. So next slide. here I have an example of where COVID-19 is not the underlying cause of death here, in the sense that the physician at this time felt that the immediate cause was heart failure, and that was due to a myocardial infarction. Yes, the person had COVID-19, but in particular clinical illness and the sequence of events leading to the death, it did not indicate that it was due to COVID. However, it's possible that the presence of COVID may have aggravated it, and so it has been placed in part 2. Next slide, please. Next slide. So to those who are the coders among us, I know some of you all may not understand some of the jargon that I'm about to use, but to know that the coders, their primary target is to find the underlying cause of death. And so, as Velma identified, and I'll just recap, the underlying cause of death is the disease or injury that started the train of morbid events leading directly to death, or the circumstances of the accident or violence that produced the injury. So ultimately, with everything that is written within that cause of death section, or even in the wider medical certificate, the UC is a primary target for the coder because it aids with the disease prevention control. Next slide, please. So the coder's responsibility here is to assign the correct ICD-10 codes, and I am saying ICD-10 here because in the region we are currently using ICD-10 and not yet ICD-11. So to code all the causes of death on the medical certificate of death, use the rules and guidelines, WHO rules and guidelines, in terms of correctly assigning or selecting that underlying cause of death. And we want to note here, the coded conditions are only as accurate as what has been written on the certificate. So then again, the physician's rule is really important, what they write on the death certificate. Next slide, please. Already been said what the codes are for ICD-10 for COVID-19, but in red, I just want to highlight it's U07.1, but it's not U07 alone, 3 digits. We are coding to 4 digits. This is a special highlight for my coders. So not using U07 alone, but you need to indicate whether it's 0.1 or 0.2. So again, to the physicians, it's important that you identify, say whether it was confirmed or if it was clinically probable or suspected. Next slide, please. So a specific note that behind our minds when we are coding to the coders, COVID-19 is not considered as due to or an obvious consequence of anything. In analogy, this would be what we would be thinking of in terms of influenza and emerging diseases reported to WHO. And further, there is no provision in the classification to link COVID-19 to other causes or modify its coding in any way. So when we are using our rule set, we will not have to apply the modification rules. And for example, COVID-19, in the sense, is not due to or give rise to, or does not cause, other diseases do not cause COVID-19. So for example, you will not have myocardial infarction leading to COVID-19. So that's basically what that's saying there. Next slide, please. So in these examples, last few slides that I have here, so this would be a straightforward case in the sense that we're seeing a type 1 respiratory failure. So these examples were actual certificates sent from member countries. So this particular one is a type 1 respiratory failure, and it was due to bronchopneumonia, and it was due to COVID-19. Confirmed. So straight away, we know it's UO 7.1, and then for the codes, as we see in blue, J960, J180. And if you notice in this particular certificate, the physician has identified the duration. They've given the 15 days for the type 1, 18 days bronchopneumonia, and has actually said approximately 3 to 4 weeks. And they did not know, but they actually did put in the approximation. So using our general principle rule A, we have there's one cause per line. We have a sequence terminating the first mentioned condition, and so therefore our underlying cause of death here would be UO 7.1. And notice I have not said TUC or the tentative underlying cause because we're not doing modification side based on the WHO rule I mentioned earlier. Next slide, please. This second case, we have acute respiratory distress syndrome, no duration given, COVID-19, pneumonia, 2 conditions on the same line, 7 days duration given, and hypertension, 3rd line. Next slide, please. So straight away, there are some red lights here that I want to flag to you. And so this was, again, I'm pointing out, this is a certificate that we received. Okay, first thing we'll note is duration is not consistent. We only have duration on one line, yet we have conditions on each line, A, B, C. Also want to point out that we have 7 days, but the duration that we have 7 days, it's both COVID-19 and pneumonia. Now, granted, the 7 days may be for both conditions, but again, there's some ambiguity there. We're not sure if it is or if it was or if the 7 days refers to one particular conditions and which one. So again, if for some reason 2 conditions are placed on the same line and you have you're putting in the duration, put the duration in to show for each condition, so there wouldn't be that ambiguity, even if it's the same period of time that the 2 conditions appeared or presented themselves. Next thing I want you to put, sorry, go right, yes. Thanks. Again, we would prefer 1 condition per line. So that's another example when, yes, there are some instances where, especially when it's a complicated case, you may have more than 1 condition in line, but really we recommend 1 condition on line. Next point I want to point out is the illogical sequence, because here we have hypertension on line C. And what we had said previously is that everything is induced due to position. So if I was to read this, it would say, acute respiratory the person died of acute respiratory distress syndrome, which was due to COVID-19 and pneumonia, which was due to hypertension. So based on what is written here, it implies that hypertension gave rise to COVID-19, which we know it did. So again, illogical sequence. And one other thing I want to point out here is the code that was used, UO7. Again, 3 characters, and we want to go to 1 character. That's my cue to almost complete. Just to show the coding, even if we left it as is, we look at general principle. A would not apply because you have two conditions on a line. General principle B, again, would not apply in this case, as in there's no sequence from the last mentioned entry and terminating with the first entry. And however, rule 1 would apply in the sense that there is a sequence between the J80 and UO7, making UO7 your underlying cause there. But of course, we said we're using point 1. Next slide. So probably a better way of writing this would have been 1 line, 1 condition per line, saying that it was confirmed, putting in the UO 7.1 and placing the hypertension in part 2 and giving us a UC of UO 7.1. Next slide, please. This is just an example where you will find where the myocardial infarction was the underlying cause of death and not COVID-19, and the COVID-19 is in part 2. Next slide, please. And so finally, next slide, please. Just some key things I want to remind you of. Use legible writing. I'm sorry, I just had to mention it today because my coders would not forgive me for not, again, pleading with our physicians to write legibly. We still have a number of certificates for which the writing is not legible, and we have to query them, and it keeps back the process. Avoid the use of abbreviations. Yes, COVID-19 is an abbreviation, but it's unambiguous, and so it's not a problem. However, there are other conditions for which there is ambiguity, and we really would like to stress again to our physicians not to use abbreviations. Enter details of duration. Again, many times then we see it missing, but we're imploring because it really helps us, especially in the COVID-19, to better understand the different conditions, when they kick in, and how long, and look at it across the board, across all our cases. Record diagnosis as precisely as possible, utilize additional reports, give information on disease, and the details of the circumstance. Always have an entry on the first line. Use a logical sequence, as I showed you, because it does lead to confusion. And do not place the underlying cause of death in part 2. Because again, part 2 is for contributory causes. Do not report mechanistic terminal events such as cardiac arrest, those things that are vague and give us no added information. And do not report the symptoms or the signs. Next slide, and thank you. That's my end. I would like to introduce the next presenter, who will give us some more examples of COVID-19 certificates. And he is Jermaine Martin. He's the Director of Health Record Services Planning and Evaluation Branch, Ministry of Health and Wellness in Jamaica. And welcome, Jermaine. Over to you.
Hi, thank you, Angela. Good morning, everyone.
Good morning.
It's a pleasure to join this webinar to share with the audience some clinical examples of the certification of death due to COVID-19. As Angela mentioned, I'm Jermaine. Slide, please. Next slide, please.
Jermaine, I think you need to raise volume on your mic. We can hardly hear you.
Okay.
Well.
I hope that is better now.
You may actually have to speak louder then.
Yes. Okay, so just to give a brief overview of what the COVID-19 situation is in Jamaica currently, we would have had 621 confirmed cases on the island and approximately 226 persons per 1 million people. Of this total, 430 have since recovered fully, and unfortunately, we would have had 10 deaths recorded so far. Next. All right, so pretty much it is very important to note that physician COVID-19 must be recorded on the medical cause of death certificate, so all descendants where the disease caused or is assumed to have caused or contributed to that death. This is very important, especially for the compilation of the country's mortality statistics. Next. As healthcare practitioners, the production of accurate quality mortality data is paramount, and physicians and coders are encouraged that in the documentation of COVID-19 confirmed cases, It must be clearly stated. And the WHO guidelines indicated that both the COVID-19 virus identified case can be used as well as in the case where the virus is not identified. And I think Angela in her presentation had touched on that as well. The COVID-19, as I mentioned, must be recorded on the certificate, and hence as Angela mentioned, the rule for selection should be waived in this regard because the COVID-19 condition is not due to another condition or anything. But for recording on the death certificate, it is important that potentially contributing comorbid conditions, they should be recorded in part 2 and not in the section 1 of the medical cause of death certificate. It is very important that a manual plausibility check be done for the certificates where COVID-19 is reported but not selected as a single underlying cause of death on the certificate. So once there are mention of COVID-19, it should be reflecting on the MCCD as well. Next slide, please. Now we're going to be looking at some clinical examples of certification of deaths, some international ones and 3 or so local ones that we would have in partnership with the Registrar General's department here in Jamaica, the organization that is responsible for registering of our deaths. And they're also joining the call. Next slide, please. Okay, so pretty much here, this is a correctly completed medical cause of death for a COVID-related death. And without repeating what Angela would have gone through, if you notice the sequence in which the documentation was done from line A down, and you notice on line C, COVID-19 as the correct, the causes of death was clearly stated. You would have indicated, you would have also noticed in red, in section, highlighted in yellow in the part 2, cerebral palsy, which would have been a comorbid condition that has no direct contribution to the cause of death. In other words, it would have perhaps been an irrelevant cause that does not immediately lead to death. So, as Angela mentioned, too, it is very important that the time of interval of onset of death be clearly stated on the medical cause of death, in addition to the general sequencing. Next slide, please. Okay, so this is a de-identified copy of an original MCCD for one of our 10 deaths on the island. And if you notice, Angela mentioned sometimes the handwriting for the clinician can be atrocious. And if you notice, this one is not so bad, but the personal and demographic information would have been completed. One of the major problems we would have had as coders, and it's a international problem, is that the MCCD is not correctly completed by physician. This one, you would have noticed that there are some unchecked boxes indicated there. Usually it is advisable that all applicable checkboxes are completed. If you notice here that COVID-19 and pneumonia is recorded on line A, and the duration would have been 4 days, the comorbid condition, 2 of which would have the doctors indicate that they would have been unknown to them. But however, the ischemic heart disease, the person would have had for a period of 18 years. So that is in fact correctly recorded in the section 2, which accounts for comorbid conditions. Next slide, please. Okay, so this is another one, COVID-19 related death. You would have noticed here that it is kind of jumbled somewhat, but it is clearly stated in terms of the duration of period of onset between death, and COVID-19 would have been included as on part B. So it is very important that this is recorded on the MCCD for clarity where applicable. Next slide. Okay, so this is another case, and whilst there are other immediate conditions, you would have in fact realized that COVID-19 was entered on the lowest use line due to the sequencing of the activity. So you will realize that the patient had cardiac arrest, which was of an interval of 1 hour, followed by septic shock and multiple organ failure, which was within 7 days, followed by COVID-19, which is in fact in the 14 days period. And all other areas would have been correctly completed. Next slide, please. Okay, so as Angela mentioned earlier, there are other conditions that are that may not be directly contributing to COVID death. So this, in fact, this example tells us about medical cause of death for a COVID-related death that for a person who would have been pregnant. So if you notice, the other condition would have been listed there, and COVID-19 written on the last use line, and particularly for the coders, you realize the change in the codes because you are using both the obstetric O codes along with the U codes and the J codes, a combination of both. So it's very important that this is done, and so we're imploring once more that proper documentation be done by our physician in order to facilitate this process. Next slide, please. Okay, so this is a non-COVID related death, and in fact the person died due to a motor vehicle accident, but would have had some relevance of COVID-19. So if you notice, the COVID-19 was indicated in the comorbid section because you would realize that based on the hypovolemic shock and the aortic dissection due to a motor vehicle accident, these would have been the underlying conditions that would have led to the person's death and not so much the COVID-19. Next slide, please. In wrapping up, these are some of the examples used by certifiers to describe COVID-19, and they can be coded as a synonym of COVID-19. Now, there are different, as you are aware, there are different strains of the coronavirus, and it is advisable that for the COVID-19 related one, it is clearly indicated. So, in some of the documentation, we would have noticed COVID-19 positive, coronavirus pneumonia, COVID negative, COVID-19 infection, SARS-CoV-2 infection, coronavirus 19, etc. So it must be clear. You cannot just have COVID on the MCCD, but it must be clearly stated whether or not it is linked to COVID-19 in fact. The next slide, please, would have been basically so far, as you notice, this is gives us a vivid picture of some of the main synonyms that can be used in the documentation. Thank you very much, and I hope that this information was useful.
And thank you to our presenters. My name is Patricia Solis. I work at PAHO with Vilma. And thank you again for joining us, and again to our presenters for the excellent presentations and the information. We all know now that high quality data is more important than ever. We received some comments and questions, and the first question that I would like to read and share with you is for Vilma. And the question is, do you have any or a guidance on how to improve at country level the recording of underlying condition during COVID pandemic? Over to you, Vilma.
Thanks for the question. What we have is these recommendations for the guidelines, the international guidelines for coding and classifications of COVID-19 deaths. And we are going to disseminate, to give it to you, and we have these recommendations on the PAHO website.
Thank you, Vilma. And for Jermaine, we received a question. Is there any specific guideline in Jamaica on how to fill out the death certificate properly?
Thanks for that question. No, what we relied heavily the guideline supplies by the WHO in terms of those. We also use the guidelines on the PAHO virtual campus that speaks to the correct filling of the MCCA. Most of our clinicians would have gone on and do that test as well, and so the knowledge is really garnered from those publications and documents that are on that website. Thank you. Over.
Okay, thank you. And for Angela, we have this question. Could we indicate pending confirmation in the certification for suspected death tested by acceptable method, but confirmation is not yet available prior to that?
Thanks, Patricia. Yes, you can put pending. That's provided, though, that you have a system that's within country that it's easy to get back to or follow the system through to be able to update the certificate. So yes, you can put pending, and generally what would happen in a case like that is the coder, once it's been certified properly and they can trace back the origin, they will call either hospital and or physician to get the confirmation. If, for example, the country is way behind and for some reason isn't able to, they'll have to code it as probable.
Okay, thank you.
They do call.
Okay, thank you. Thank you, Angela. And also we have another question that is for Jermaine. What if we have a case where the case was suspected of having COVID-19 and the test was positive, but the person commits suicide?
Usually in that case, once it is known that you would have seen one of the examples I shared, the person had COVID-19, but in fact, the sequence of events, the person was also involved in a motor vehicle accident, and so the cause of death was the MVAs and not so much for the COVID. So in a case where you would have had suicide being recorded as the death, that would have been listed first, and the COVID-19 would have been recorded subsequently in the comorbid section.
Okay, thank you. And we have also another for you, Jermaine, that is one of the examples show has both COVID-19 and pneumonia on the same line. Shouldn't they have been separated as Angela indicated?
Yes, they should have been indicated, and in fact, that was, as I mentioned, we have been imploring on the clinicians to correctly complete it. In that case, that should have been recorded on the line below, because it advised ever based on the guidelines that each condition recorded individual on the line. So that was in fact an error in the documentation, but you cannot change what the physician documented as coders. You rely heavily on the information that would have been indicated on it. But in fact, that was a good observation. It would have been recorded below. Thanks, Patrice.
Okay, thank you. I know that we are getting close to time, but I really want to ask two questions because both are very important. The first is for Angela. How do we have to code if the certificate, the doctor writes COVID-19, nothing else, just COVID-19?
Yeah, we generally ask our coders as far as possible to go back to source to see if they can get added information to know how to code. Now, granted, this does not change the death certificate. Sorry, you might be hearing a lot of noise behind me. It's raining. It does not change the official certificate that has been lodged and the family already have, but it helps with respect to the coding, which directly relates to the public health aspect. So you can call, get the information. If it's not available, then you're going to have to assume that it is it's suspect, it's probable. However, you do have in the case of certain countries where the country is small and the case load was very small and it was extremely publicized already that all the cases were confirmed and etc. And you know specifically that it is part of your, say, 2 cases that you have, you may want to consult in terms of supervisor and code it as it really is, which is really COVID death. Yeah, but generally, most of our coders are able to go back to source and get it and figure out if it's confirmed. But it's so much easier if the physician writes confirmed. And also, too, we have to take into consideration, God forbid, a situation where the system is overrun with cases, and therefore there is a lot of unsure. It's not clear. There's no way they would be able to say follow it back, and the onus is really on the physician at the time to be able to say yes or no, suspect or not, confirmed or otherwise. Over.
Okay, thank you, Angela. And this is for Vilma. Are the U071 and U072 codes to be used regardless of the version of ICD? For example, ICD-9 or ICD-11?
Thank you for the question. For ICD-11, we have other codes. I showed on the slides, and we have these codes in the document. For ICD-10, we have used 07.1 and 0.2, and for ICD-9, no, we don't have any codes. So the recommendation is to use, if someone is using ICD-9, is use U07.1 and U07.2. Different codes just for ICD-11. Thank you.
Thank you, Vilma, for the clarification. And this for Jermaine. If someone is COVID-19 positive and then die of sepsis after second COVID-19 PCR was negative. Will COVID-19 still be the underlying cause of death?
No, because if the test is negative, or perhaps if the test came back negative, it would have been recorded as that would have been a suspected case, so it would not have been a confirmed case, because you can only indicate that the person is COVID-19 positive by a test result. So in fact, the outcome of the result would would indicate what is to be written on. So in fact, sepsis would have been the major cause if the COVID-19 test result is negative in that regard.
Okay, thank you. And this is, I think, the last, and thank you for your patience, but it's very important also, and it's for Angela. If death caused by multi-organ failure and complication like respiratory failure simultaneously with heart failure and documented liver failure with COVID-19 as the underlying cause, should all causes be written in the part 1 on the certificate, and would 2 entries on 1 line be accepted?
Yes. In that case, we err on the side of more information than less. And yes, there are that's another slide I have for those complicated cases where you have multiple organ failure and lots of different conditions on how to report them. But I would say err on the side of entering it all. Even though you may have more than one condition on a line, it is how should I say, it is covered in terms of we have guidelines and way to treat with it, but no, as a rule of thumb, usually we take the condition that was written first to be the order of importance. So if you had, say, 2 conditions on the same line, and say it was, I don't know, say liver failure and I don't know, some other condition, we would, as a rule of thumb, consider the liver failure that was written first to be in the physician's mind as being that's more critical or pertinent than the next one that was written. So, and we would use that in terms of the order of importance. So yes, put it down. You're in the side of too much rather than too little.
Okay, thank you very much, Angela. Okay, now I need to make the close remark. Thank you to our presenters, Angela, Jermaine, Dr. Vilma, and thank you all for joining us. Please note that this session has been recorded, and we will circulate this recording as well the presenter slides to the group. Thank you again for your participation, and have a very nice day.
Thank you very much for participating.
Thank you. Bye.